Dr. Amanda with Straightsmile Solutions, straightsmilesolutions.com, and today we're going to do a three-part series on case selection for general dentists. This is my recommendation, what cases to take, what cases to not take, depending on your experience level. So we're going to start first with the green light cases. Green light cases means these are cases that any general dentist or pediatric dentist can take and should take. This is where I want you to get started. When you're first getting started, for your first 50 to 100 to 150 cases should be all green light cases. So let's go over the criteria. So class 1 cases, class 1 molar and canine. Check both your molars, check both your canines. If your patient is missing teeth, nope. I only want you to pick cases with all the teeth in from 7 to 7. That means from second molar to second molar, okay? And that's point 2, no missing or impacted teeth except for third molars, okay? That's it. And matter of fact, I'm not super thrilled if third molars are erupted. I'd actually rather than be out or impacted because it just complicates things. Like really impacted, not like partially impacted, like in the bone, high and dry, not in the way, okay? Class 1, so I don't even mean, you can't even be 2 millimeters class 2. Solid class 1 molar and canine, all four, all the bites on 4 different bites on all sides, all 8. Okay. No history, past or present, of periodontal disease. That means we don't have recession, we don't have furcations, we don't have, probing issues. Nice 2s and 3s on probing and no attachment loss. Okay, so you're getting the idea. This is a young patient. We're talking teens and 20s probably, okay? Most likely, could be 30s, not older patients. And I know this is harder because those of you who are general dentists, a lot of your practice is older. We're gonna get there. Those are gonna be more advanced. It just complicates things and it makes it less predictable. So I'm trying to have you stick with super simple cases. And I realize with these restrictions, it's gonna be a very small percentage. Now, it's okay if you're taking yellows, which is we're gonna get to, but you need to have an orthodontic consultant helping you with those yellows. These you can do on your own. It shouldn't be hard. Okay, next, in terms of, these should just be crowding and spacing cases only. Nothing weird, okay? Mild to moderate, less than 6 millimeters. You should know how to count that. It should be pretty darn obvious. That means it's not gonna look that severe. These might be patients that usually have had ortho before and they relapsed. So most likely it's or they could be teenagers, just very, very simple teenagers. It's probably not gonna be adults that didn't have ortho before, okay? So let's talk about the vertical. When they bite down in front, we want to see a certain percentage of their lower incisors. That's what we mean here. So we want to see at least 90% of their lower incisors, 80% of their lower incisors, 70, 60, 50, 40, 30. But if it's anything less than that, if I can't see the lower incisors at all, or if I only see a little bit, that's a no. If there's any type of anterior open bite at all on any of the front teeth, it's a no. Okay, you got to have some overlap on all 4 of the front teeth. That's what I'm talking about. So not a severe deep bite case and not even a tad of an open bite case. Pretty normal vertical, okay? No open bites. Also, no cross bites of any form. No posterior cross bites, no anterior cross bites, okay? Everything is perfect in terms of the interdigitation of the back teeth and no anterior cross bites, no open bites. You get the idea, okay? So this is your green light cases. Go for it. You can do these yourself. You can probably do these with any aligner brand out there or braces. Should be super easy. There shouldn't be any complications, assuming that you treatment plan it properly. All right. So do these cases. Thanks. Hey, it's Dr. Amanda with Straightsmile Solutions, straightsmilesolutions.com. And today we're going to talk about yellow light case selection for general dentists. Yellow light means that for me, it's for dentists who have done at least and finished at least 50 aligner or braces case. It doesn't mean started. It means finished optimally. And they feel like they can tackle it, or dentists that are willing to work with an orthodontist to help them. We do this at Straightsmile Solutions. We'll help you with your cases, but there's a lot of other orthodontists that do too. So you want to get orthodontists that are, of course, US licensed. That's really, really important. There's a lot of orthodontists that are doing this in foreign countries. I do not recommend that. US licensed orthodontists who are trained in removables and fixed, who have the time to sit down and help you with your cases. So this would be the yellow light cases. This is not something you want to tackle on your own unless you're very, very, very experienced and you've finished at least 50 cases ideally. So this is a little bit of what we're looking at. So a little more complex, building on the green. So make sure you watch the green video first, and then we're going to talk about yellow. So this would include slight class 2 cases, molar or canine up to 4 millimeters, not full step class 2, slight class 2. Obviously, in teens or growing kids, for these type of cases, you might be using MA, you might be using twin blocks, you might use elastics, most likely not. In adults, we might do sequential distalization, we might do elastics, we might do IPR. Obviously, it's going to depend on the sagittal slice of or the ceph. We're going to have to check that, you know. You got to be, if you're going to take these type of cases, you need to have a way to either take a sagittal slice CBCT or a ceph on every single patient. If you do not have that ability, you should not be taking yellow cases. And this I really have to hammer home, because there's a lot of dentists who have skills, but they're not getting the right diagnostics. That opens you up to liability because you're just guessing on the treatment plan. And a lot of times these dentists are asking me to help with their cases, and I'm like, I don't have x-ray vision. I don't know. You know, I don't know what the right thing to do here is. Most orthodontists take cephs standard on every single patient, just in case we need to refer back to it. And also for, you know, standard of care. All right, what else? Edge-to-edge cases, anterior crossbite only, not posterior crossbites, okay? So that means we either have just edge-to-edge. I'm not saying a full anterior crossbite, edge-to-edge. That means the front teeth are hitting, boom, boom, right on top of each other, okay? Those are easy. I mean, we either do a ton of lower IPR, or we take out a lower incisor, or we take out, make sure the third molars are out, and we slide the teeth back. Deep bite and overbite cases, any severity. So we'll take whatever, you know, 100% deep bite, fine, no problem. We can handle that. We can take a minor open bite up to 2 millimeters, as long as you know the etiology of the open bite, what caused it. You can't guess, you need to know, which means you're either going to have to send your patient to OMT, to a sleep specialist, okay? You have to do the OMT workup yourself, but then know about the treatment. This is most likely going to involve OMT. If you don't know what OMT is, you need to go through my whole OMT playlist. You can go to my YouTube channel, put in the search bar with a little magnifying glass, letters OMT, and all the videos should come up. If anything I'm mentioning you can't find within my channel, you're more than welcome to email me, info@straightsmilesolutions.com. Go to my website, straightsmilesolutions.com, send me a website message, and I will give it to you. No problem. So you need to know what caused it, and that cause has to be fixed before you get started. Like the OMT says it's okay for you to take this case. Remember, OMT is going to add a couple $1,000s onto the case unless you're offering OMT services in your practice, which you can. It's not hard. You can get your hygienist trained in less than a month. Sometimes even less than a week if they really go for it. And you can start billing for that. Sure, it's not going to cover, so it's cash, you know, but the OMT treatment or the habit treatment needs to be completed, and that is not patient's word. That is someone actually evaluated it, signed off saying that the habit is gone. There's still an open bite because of the habit. Any patient that has an anterior open bite either has a habit that needs to be fixed or needs jaw surgery. There's no other way around it. And I can't say this enough times. Any patient with an anterior open bite, you can't go straight into Invisalign. You can't go straight into braces. It will relapse and weird things will happen. Sure, they're going to make a Clin Check for you, but it's not going to happen. I can tell you that. And it's not going to retain. So I'm going to keep saying this again. Any patient with an open bite must finish their OMT therapy and get a sign off from the OMT. A sign off in writing saying the habit has been eliminated. Unless you have that from their OMT, not them saying it's gone, then you can go ahead and proceed. Otherwise, it is a jaw surgery case and you got to punt that out. All right. We'll take a patient with mild periodontal disease with some attachment loss that has been treated. It's under control, less than 3 millimeters of attachment loss, which means this is going to take you up to people in their 40s and 50s, possibly 60s, probably not older patients, sometimes younger. You've also done a 1-month evaluation, completed and charted, and all pockets are less than equal to 3 millimeters and no major mobility. Okay, so mild perio, mild. Anything else is now a red light, okay, which is not something you should be taking. Weird things can happen and do happen. We'll take posterior crossbite cases in kids and teens. And 13 years old, it could be 14, 15, but in kids and teens, because we can fix those. Now, you're going to have to do some type of additional treatment, so you should definitely consider taking a phase 1 course. We do have one available. I have some promo codes that might still be available. Feel free to contact me. It's very affordable, and you get 13 CE units. In addition, you can take mixed dentition cases. kids and teens that haven't lost all their teeth, still growing, lots of things we can do there. Very, very easy. Fix the growth issues first, fix the bites first, move on to straightening teeth. Not hard. You should not be afraid of those cases. These yellow light cases include a lot of potential cases. That's probably 50% of your practice. It's going to increase your starts significantly if you're willing to do yellow light. But again, you have to have a lot of experience or you need to be working with an orthodontist. Hey, it's Dr. Amanda with Straightsmile Solutions, straightsmilesolutions.com. Now we're going to talk about red light cases. These are ones that I don't want you doing. Refer them out, refer them out, refer them out. Unless you've done a couple hundred yellow light cases with an orthodontist and you have an orthodontist to help you with the red light cases. If you're relatively new at ortho, I do not want you taking these cases. Nope, you're going to hate it. You're going to struggle. Weird things are going to happen. These are hard even for orthodontists, and I can't always predict what's going to happen. So these are some guidelines to not take these cases. Impacted canine cases, okay? You can take a buccal impacted canine case. How do you know it's buccal? Watch my impacted canine playlist to find out. Obviously, you probably have to get a CBCT too. Okay, not palatally impacted, buccal. Full step class 2 cases, especially kids that are growing, we can definitely deal with that. In adults, we might not be able to fix that. Depends on the ceph. Negative overjet, slight class 2 up to 2 millimeters. Sorry, class 3, up to 2 millimeters. 2 millimeters, not full step class 3, 2 millimeters. Okay. Anything else is a jaw surgery case or just incredibly difficult and probably can't be fixed. Open bite cases up to 4 millimeters in front. That means if one tooth has 4 millimeter open bite, that's a red light case. Again, go back to my yellow video. I talked a lot about working with OMT. You do not take any open bite cases, not even 1 millimeter, unless they have done their OMT treatment and they have a sign off from OMT. Okay. Not the patient can't say, I stuck my thumb and now I'm done, because you know what? There's a lot of other sequelae that happens that you may not be able to see. Let the OMT help you out. Remember, that's going to add a couple thousand to the cost. You're going to have to outsource that unless you have OMT in-house that's trained and licensed. Not hard to get your hygienist up and running on OMT. Not hard at all. You can do it in a week or two. Cost a little bit of money, but they're going to bring in a lot of revenue and you can take harder cases. It's a super smart idea. If you're going to take harder ortho cases in your practice, you need to have one of your hygienists excited about doing OMT and doing it. And then also moderate perio cases. Any cases, even if it's not a hard case that has moderate perio, so many weird things can happen. It's still a red light case. That means you need an orthodontist to help you out with those cases, no matter what. All right. Otherwise, these are all referral out cases. These are ones, do not pass go. Refer it to your neighborhood friendly orthodontist. They can handle it. Thanks.